Thank you so much for joining. Good afternoon. Um, the webinar today is Defend Progress, Extend Coverage, Empower Consumers, Protecting CGM Access at the State Level. My name is Mackenzie Marshall. My pronouns are she, her, and I'm the Senior Manager of Government Relations at Families USA. I'm so glad that you're here today. And before we get started, a quick sort of reintroduction to Families USA. For those who may be new to our network or new just today on this webinar. We're a national nonpartisan nonprofit voice for healthcare consumers. And if we could go to the next slide. These are our four strategic goals. Give us a little bit a deeper description as to who we are at Families USA. And we'll go to the next slide. So for the last few years, we've been working in Alabama on improving access to continuous glucose monitors, and this is our first webinar with a national focus. Today, we're going to start with a state of play update on the highlights of the essential role that CGMs play in diabetes management. We'll also review the American Diabetes Association standards of care and talk about how states are currently aligning with those standards. We'll then go through the existing state CGM coverage framework and transition into our panel discussion. And then we'll end today with a short Q&A and some calls to action. A few housekeeping notes before we dive in. If you'd like to participate at any point by asking a question, please use the Q&A chat at any time. The Q&A function is found at the bottom of your screen. We encourage you to use that form of engagement to add in questions because we'll be monitoring that throughout the webinar, but you can also add in questions to the chat if you're more comfortable with that. And we will weave some of the submitted questions that come through the Q&A into the chat, through the Q&A function and the chat into the Q&A portion of our webinar later on. To close out the session, we will talk about ways to stay involved in this advocacy network and this advocacy effort. So you'll hear more about that later on. And please note that this session will be recorded, so we will be sending out the recording. And in addition to that, some quick top-line notes for you to read later on. As is our policy, our team will remove any AI bots if they're detected. And please rest assured that we will continue monitoring that throughout the webinar as well. So for closed captioning and translation services, you'll also find that at the bottom of your screen. Please click the CC and you should be able to access that. And if you experience any technical issues, please feel free to message my colleague Emma Green, who's on the webinar today, in the chat, and she'll be able to help you out. So now on to our speakers. We're joined today by an incredibly knowledgeable panel. We have Greg Howe, who's a senior fellow at the Center for Healthcare Strategies, Honor Hill, the director of maternal and infant health initiatives at March of Dimes in Alabama, and Bruce Taylor, who's a healthcare advocate who's joining us to tell us a little bit more about his personal story with diabetes. You were also supposed to hear from my colleague Ben Anderson today, who's the Deputy Senior Director of Health Policy at Families. Unfortunately, he's sick and out of the office, so I will run through his section of the state of play, but he remains available for any questions or any technical assistance requests after this call and moving forward, and we'll make sure to provide his email as well. And then we can move on to the next slide, please. Thank you. So, let's start with sort of a foundation of the problem, the burden of diabetes in the United States. According to the Centers for Disease Control and Prevention, 38 million Americans are living with diabetes, and this accounts for 11.6% of the US population. A further 8.7 million adults 18 years and older are living with diabetes but remain undiagnosed. This disease disproportionately affects American Indian and Alaskan Native communities, Black Americans, and Hispanic communities, deepening existing health inequities. And the burden of diabetes is not just physical, it's also financial. The American Diabetes Association estimates that in 2022, diabetes cost the United States $412.9 billion, representing 1 in every 4 healthcare dollars spent in the US. And notably, Black Americans with diabetes face the highest direct healthcare expenditure costs. We can go to the next slide. So what are continuous glucose monitors and how can they help? Continuous glucose monitors, commonly known as CGMs, are small temporary wearable medical devices that attach to the body and track blood sugar levels continuously throughout the day. They send real-time data directly to a patient's smartphone, a handheld receiver, or an automatic insulin pump. For children using a CGM, this information can also be shared with their parents or caregivers. This real-time data helps individuals recognize patterns, avoid dangerous high and lows in blood sugar levels, and make informed decisions about their care. When used in partnership with healthcare providers, CGMs have been shown to significantly improve blood sugar management, reduce healthcare costs, and lower the risk of negative health outcomes. So, are CGMs covered? Go to the next slide. This map highlights the current CGM coverage status across the United States. As you can see, at least 28 states now offer comprehensive coverage, meaning that coverage for people with type 1, type 2, and type diabetes and gestational diabetes is covered. And while this represents meaningful progress, there's still much more work to do. States that are shown in cornflower blue have made important strides, but their coverage status does not yet meet the ADA standards of care. So, for example, today we're joined by Honor Hill from March of Dimes, Alabama. She'll share a little bit more about recent expansion efforts in her state. And Alabama has made really impressive progress in the last few years, but it remains in cornflower blue because it has limited their coverage expansion to folks who are just insulin dependent, requiring 3 or more injections per day. Um, my colleague Ben is available to break down this map and our coverage criteria for how we develop this map. If at any point you have any questions about it or if you want to learn more about your state, please feel free to shoot us an email. We're happy to talk it through. And I do want to give credit to Greg Howe, who's on this call, and Bruce Taylor, as well as some of the other folks that we work with at the American Diabetes Association. All of this information and this map was really born out of a concerted effort to make sure that we were just updating existing work that had been done. So we owe everyone who's on this call, but also more broadly within the diabetes advocacy community, a debt of gratitude. So thank you so much. And we're happy to provide this resource, and we will provide a more designed resource later on after the webinar. Go to the next slide. So what are the ADA standards of care? In 2025, the American Diabetes Association published the standards of care for diabetes that clearly outlines who should be offered a CGM. They recommend CGMs for everyone on this list. So people with early type 1 diabetes, youth and adults who are on any kind of insulin therapy, adults being treated with type 2 diabetes with glucose monitoring medications that are not specifically insulin, those who might be at high risk for hypoglycemia, and adults who are pregnant and have type 1 diabetes or adults who are pregnant with any type of diabetes. We believe it's critical that adults, children, and pregnant people have the tools that they need to successfully manage their health, and expanding access to CGMs is a powerful step towards reducing inequities, improving outcomes, and supporting millions of Americans who are living with diabetes. I'm now going to turn it over to Greg Howe, who's also going to join us on the panel from the Center for Healthcare Strategies to tell us a little bit more about the CGM state of coverage framework. So with that, we'll keep the slides up and transfer it over to Greg.
Greg, you're muted.
Sorry about that. I made sure my screen was off, but I didn't think about the video or the sound. So sorry about that. So thank you, Kenzie, for that great overview, and thanks for the opportunity to be here to talk about expanding access to CGMs in Medicaid. Next slide. Just a quick overview. For those of you who are not familiar with the Center for Healthcare Strategies, we are a nonprofit policy design and implementation partner dedicated to strengthening the U.S. healthcare system to ensure better, more equitable outcomes, particularly for people served by Medicaid. And we do that by partnering with Medicaid stakeholders to promote innovations in healthcare delivery where they are needed most. And in a few minutes, I'm going to talk about the work we're doing specifically around a learning collaborative for states that are interested in expanding access to CGM, which is a pretty typical kind of program that we work on. Next slide. So as Kenzie mentioned earlier, there's no consistent Medicaid coverage policy across the United States. Back in 2002, my organization published a report on the state of like an environmental scan on coverage for CGMs. Since that time, there's been a lot of steps forward, but there's still no consistent Medicaid coverage policy across the United States. There are differences in who's covered, meaning coverage for people with type 1 versus type 2, coverage for children versus adults, There's differences in diabetes specific requirements of medical documentation, prescriber requirements, the need for prior authorization. There are different types of prior authorization and differences in where and how patients get their CGMs. So these state Medicaid coverage guidelines are kind of burdensome, and the restrictions create unintended consequences that may worsen disparities for people with diabetes. Next slide. So I wanted to just share a few key areas of where the states are moving. We can't really get into every iteration of coverage across the map, but I just wanted to show or just kind of highlight a couple areas that we're seeing movement and areas where we think patients, beneficiaries would benefit from changes in policy. And just to point out one, well, I'll get to that in a second. But anyway, so let me start with pharmacy versus durable medical equipment benefit. So there are different ways that CGMs can be delivered, and those are two of them. Some states deliver their CGM benefit through the pharmacy benefit, and some do it through their DME benefit, and some do it through both. So states are increasingly classifying CGMs as a pharmacy benefit versus a DME benefit, and this enables patients, and this is what we've heard by talking to patients and providers and others. It allows patients who are already getting their diabetes supplies through a pharmacy to avoid navigating the requirements of another entity, a DME provider. So it just kind of eliminates some of the bureaucracy around that, and it's just easy for patients to access their devices that way. The second thing I wanted to highlight is removal of prior authorization. So states are beginning to remove prior authorization requirements, especially under this pharmacy benefit. And this, I think, it's pretty clear that this provides patients with more timely access, reduces the paperwork burden for providers, but there's still a lot of requirements out there around prior authorization, and states are looking at it at different ways, and I'm going to highlight a few examples in a minute. And then the last thing I wanted to mention is expanding coverage to type 2 populations. So states are including people with type 2 diabetes, both people who require insulin and also people who don't require insulin, and also expanding coverage to people with gestational diabetes. And that's, the ADA guidelines that Kenzie referenced earlier. That's part of what those guidelines would suggest. Next slide. So we're wrapping up the current phase of the Accelerating Access to CGMs and Medicaid to Improve Diabetes Care project. It's kind of a mouthful, but we call it the Access Accelerator. And the goal of the project is to increase CGM access, improve clinical outcomes and quality of life, and reduce healthcare costs and reduce disparities for beneficiaries with insulin requiring diabetes. And I mentioned insulin requiring, but I mean, we're covering others with diabetes that could benefit from a CGM that don't necessarily require insulin, but that's sort of the official way we started the project a few years ago. So the project includes 7 states: Iowa, Kentucky, Michigan, New Jersey, Oklahoma, South Dakota, and Texas. Many of the states wanted to participate in the initiative because they knew that CGMs were proven to work and that their beneficiaries weren't always getting them. They also knew that there were disparities in who was getting them and not getting them. And they knew that they needed to change their policies, educate their providers, and support their beneficiaries. So we provided ongoing TA from us and other experts to do this. We also developed a resource center, which houses nearly 80 peer-reviewed articles, practical tools, and other resources specifically aimed at states and state Medicaid agencies to help them design and implement strategies to expand access to CGM. So those resources are available on our website, and I'll talk a little bit more about that in a minute. We will be launching the next phase of the project after the first of the year, and we're hoping to add more states, maybe Alabama, maybe other states that you all work in, but we're we're pretty excited that that will be expanded. And the support from that comes from the Helmsley Charitable Trust, which I'm sure many of you are familiar with. They do a lot of work in specifically around type 1, but diabetes generally. And we're grateful that we're able to work with Medicaid in that way. Next slide. So the state work has been going on since about 2 years ago, since the fall of 2023. And the cohort of states have made tangible progress. So the reason I'm talking about this is because I want to share some of the things that the states are doing. I think that can give you all ideas about, I mean, obviously in expanding coverage is very important, but there are other ways that states can sort of go beyond that to make sure that their beneficiaries are getting the CGMs that they need. So two of the states, Iowa and South Dakota, moved CGMs from a durable medical benefit, the DME benefit that I talked about earlier, to a pharmacy benefit. Texas and Michigan are both considering doing the same thing. Again, this is really important because getting a CGM through a pharmacy is better for patients who are already getting insulin and diabetes supplies there. And it's generally cheaper for states and it's better for tracking utilization. We even published a tool to help states with making that change. So that tool is available for states that are thinking about doing that. And it leans on some other states that have made progress and have sort of analyzed their results around that. Michigan removed its prior authorization requirement for people with type 1, which makes sense because there's no cure, no reason to make people go through the prior authorization process every year for a disease that has no cure. Michigan also removed prior authorization for people with diabetes in pregnancy, childbirth, and the postpartum period. And what you'll see in policies as it relates to gestational diabetes is that some states are very explicit that they cover it. Some states it's covered, but it's not sort of spelled out. But people with gestational diabetes can get CGM. So we really trying to move states toward covering it, explicitly in their benefit description. States have focused on their managed care plans. Most states deliver healthcare through managed care organizations. Michigan actually implemented a contract requirement for all their MCOs to report CGM utilization data, which is important for establishing statewide benchmarks. They're planning to include a quality measure in that. And the first step is just collecting utilization data so they can see where the CGMs are being accessed. And New Jersey is amending its contracts to align coverage criteria across all 5 of their MCOs. So almost all of their healthcare gets delivered through MCOs. They have 5 MCOs. All 5 of them had different requirements and around CGM access. So now, as of January 1st, all 5 MCOs will be required to follow a standard set of guidelines. And in that map that Kenzie showed you earlier, New Jersey was one of 2 states that didn't have published coverage. Well, now they will. And it's probably one of the most open policies that we've seen, which removes prior authorization and really makes CGMs accessible to everybody. But before I leave this policy slide, I just wanted to mention a little bit about Texas, which is, it mentioned it here a couple times earlier in the slide, but Texas did a major overhaul of their policy about a year and a half ago to align with the ADA standards and Medicare guidelines, which went into effect during the course of this project. It's pretty close to what we would consider, although New Jersey's policy is pretty good too, but it's sort of a reference point for states. I mean, there's some things that Texas is continuing to look at. For example, some of their providers are still following the old policy and submitting requirements that they don't need to. So there's efforts going on in Texas to really educate the providers to let them know that they don't have to do all the things that they had to do before, which obviously slows down the process. So there's lots of things going on there, but I really want to emphasize that ADA requirements, Medicare guidelines is another place to look as well. Next slide. And this is my last substantive slide, but I just wanted to do a quick kind of deeper dive into Kentucky. And the reason, as I mentioned earlier, is that in addition to the actual coverage policies, there's work that needs to get done. I think Texas is a good example of ways to increase CGM access. It goes beyond just the policy changes. So Kentucky, for example, has been really active in using data. So they looked at their data and utilization data and found that 30% of their members that only about 30% of their members who are eligible for CGM were actually utilizing it. And they were able to look at that data and identify geographic areas with those disparities and are now targeting those areas for both provider and patient engagement. And they also used that analysis to make a policy change. They identified that there was very, very low utilization among members with gestational diabetes. And they looked at their policy and realized that that was a barrier. So they changed the policy to make it easier for providers to prescribe and patients to get what they need. And since that policy implementation, which about a year ago, their utilization rates for members with gestational diabetes went from 7% to 42%. So a really big increase. That data is a few months old, so probably even more. But just to mention a couple other things that they're doing, that they have a member-facing website that's specific to resources for diabetes and self-management and CGM use. They created a work group dedicated to recognizing licensed diabetes educators, which are the people that are supporting patients with diabetes, so that there was more movement on that front. They worked with their MCOs to align the coverage policy, and they've done a few other things I don't have time to get into here, but really just trying to move the needle beyond just coverage. Next slide. And these are just some of the resources that are on our website. We mentioned the Resource Center, which has all these resources, but we've also created, I think there are 10 or 11 resources here that we designed and published, and I mentioned the pharmacy benefit that's on here as well. So I just encourage folks to go there or to point their policymakers there. There's a lot of really good information, and I'll stop for now.
Thank you so much, Greg. I think we can pull the slides down now, Emma. That would be great. If anyone has any questions for Greg, please feel free to add them into the Q&A or add them into the chat. We'll have the Q&A section after the panel. So just a friendly reminder that that's there. But we're now going to move into that panel discussion with Greg, Honor, and Bruce. So thank you, the three of you, for joining us today. We're so happy to have you. Now that we've covered a little bit more about the current landscape on CGM access, I'd sort of like to bring us back to why access to this technology is so important for consumers. So Bruce, I'm going to turn to you first. As someone who uses a CGM for their own diabetes management, can you please walk us through how access to this technology has improved your daily life, health, and overall well-being?
CGM is an absolute life changer and lifesaver. I was diagnosed 48 years ago, November the 15th. So when I first started out, I was using glass barrel syringes and pork insulin and giving myself a single massive dose of insulin once a day. Then I remember getting my first blood glucose meter and strip. And I calculated at one time, it's over 200,000 times I've stuck my fingers. When you CGM, there's a concept called numeracy. When you stick your finger, you get a value, but they want you to intellectually remember all those disparate numbers. CGM comes out in a graphic form on your phone or on your receiver. So it's basically a behavior modification tool. You can see what you eat and how your body responds to what you ate and the glucose that was in it. If you exercise, it lets you know what exercise does to alter your course of your blood sugar. I can share with up to 10 people my support group for getting my blood glucose no matter where I'm at in the world. I was recently in Amsterdam, 3 o'clock in the morning, there's a knock on the door, a little bit of a language barrier, and the little woman that was knocking at the door came in and handed me a bottle of orange juice. She says, "Sugar, your daughter called." It's 3 o'clock in the morning in Amsterdam, but it was 9, 10 o'clock here in the US. She got the same alert that I was getting that I didn't hear because I was fast asleep. That has completely altered it. And from the time I went on CGM, my management of my diabetes has gotten so much better that my hemoglobin A1C is at 5.7. And technically, I quote, don't have diabetes now, but I still do. But the reduction and reduce in cardiovascular risk, renal risk, dementia risk, heart attack risk, kidney risk, that's all been helping to be abated by having this little device that beeps. And you may hear my device beep because I was low and I took some orange juice. So it's running a little high now. So if you hear two beeps, that's me.
Thank you, Bruce. That's great. That's a great story about your daughter being able to see or get an alert about your blood glucose level. I'm glad that you're okay, and I'm glad that she's able to see that, and you have such a strong network of people who are there to support you.
Yes.
That's great. Honor, March of Dimes focuses on improving the health of moms and babies. Can you please tell us a little bit more about your work in Alabama to expand CGM access and why March of Dimes decided this issue was important to take on?
Yeah, absolutely. So, as mentioned, we focus on moms and babies, and we really do want the best for all moms and babies, regardless of their socioeconomic status, where they live, their race, their ethnicity, their age, and their background. And we know that chronic diseases, diabetes being one, impacts mom's health during pregnancy, before pregnancy, and even after pregnancy. And so, as we look at managing chronic diseases, but even things that come up in pregnancy, as we look at cardiovascular related issues, knowing diabetes is very much intertwined in that conversation as well, and just the overall systematic quality of life that a woman's having in her body, we want to make sure that we're focused on the whole person, including diabetes and the management of diabetes. And I'll start by saying that I feel like we have been having conversations around diabetes, but it really comes down to the fact that we have really incredible partners who have been working on this for many, many years in Alabama. I have partners, specifically the American Academy of Pediatrics, who have been working on continuous glucose monitors for so many years, of meeting with the Medicaid director and having those conversations with the commissioner and bringing it up every time they have meetings. And that's really what furthered the work that's being done in Alabama around continuous glucose monitors. But us as March of Dimes, being able to talk about the impact of pregnancy and the long-term outcomes. And it really comes down to having these conversations within a larger conversation with partners of strategies, just kind of almost of Russian dolling it as we are talking about larger issues. Well, that means this, that means that, that means that. So we're talking about continuous glucose monitors for gestational diabetes, but where that comes up is in conversations around remote patient monitoring and the remote patient monitoring system that we're going to have in Alabama. And that then comes up within this larger conversation of, well, how are we going to impact maternal and child health overall through our Transforming Maternal Health grant, through the Rural Transformation grant that the state has to apply for, how and kind of Russian dolling that question, so we're not coming up with this idea of this random idea that has nothing to do with anything else that's going on in the state. So this came up naturally as part of this overarching conversation on benefiting moms and babies long term in the state.
That's a great explanation of Russian dolling it, right? Like making sure that you're understanding every single issue within the context of the broader healthcare status across the states, both the human impact of various diseases, but also the financial impact of various diseases and what various states can take on. And I
And
know
it's
that was oh, go ahead.
I was going to say, and it's a group effort, right? So
Yeah, yeah.
we were not, I will admit, we were not the ones who were having these conversations for years and years and years, but it was one of our really important partners that we stood behind. We said, use our name if you, and we will be there to talk about gestational diabetes if you need us to. But being in that coalition and coalition building was really what drove us to be a part of these conversations, of hearing our partners say, hey, this is an important piece of the puzzle, and knowing where we as March of Dimes can come in and be part of those conversations.
Yeah, yeah. I really appreciate you mentioning the strength of coalitions and the importance of networks. And thank you so much for the work that you have done, the work, also big thank you to AAP and everyone across the state of Alabama for pushing coverage forward. That was a really that was a really important step for the state, and it was a really important step for Alabamians. So thank you for all of your effort. Greg, we've now heard from both Honor and Bruce about sort of the real world impacts of CGM access. And as we saw in the presentation earlier, states are really making meaningful progress towards that access. Why is it so critical that individual states are aligned with the ADA standards of care for diabetes management?
Yeah, that's a good question. I would say, as Bruce gave, a great example. I mean, we know that CGMs are effective in improving health and well-being. There are tons of studies. The ADA guidelines are clinically based, so they're really hard to argue against. So I think, kind of leaning on the ADA guidelines gives, it's just a really, way to make a strong argument. I mean, they're again clinically based. And they're focused on making sure patients get what they need, especially newly diagnosed patients, which is really important for newly diagnosed patients to be able to get CGMs early. Um, and that's what the standards include, those kinds of recommendations. I would also add, and I mentioned this when I was talking about Texas, that states can also look at the Medicare guidelines. Not obviously there's a little bit of apples and oranges there, but I think, in many, compared to many state Medicaid policies, Medicare policies are a little bit more accessible, more open and accessible, especially because Medicare covers for anybody with type 1 or type 2 requiring insulin. So it's not just limited to type 1. For example, and also, there are some limitations that I just didn't talk about before around coverage, where some states require certain providers prescribe CGMs, like endocrinologists. We know there's a shortage of endocrinologists, so it doesn't. Any provider should be able to prescribe. Um, you know, and also, there's some states that just cover CGMs for kids, for pediatric population, not adults. I think that's changing, and thankfully, but I think those are just, some examples where the guidelines speak very clearly about what patients should get.
Hmm. And now, sort of both you and Honor have mentioned this as well, but um, as state legislatures face increasing budget pressures, given the recent cuts to Medicaid and everything that's happened this year with HR 1, are you concerned that expanding coverage for optional benefits like a CGM and trying to push a state to meet the ADA standards of care, um, do you think that will add too much pressure? Do you think that the sort of existing optional benefits that states have expanded could be at risk given everything that's happened this year?
Yeah, I would say I'm definitely concerned. I do think, though, that states increasingly recognize the value of CGMs. I mean, it's a proven technology. It does impact health, well-being, and also cost. So I think states, and also I think there seems to be an emphasis on addressing chronic conditions from the federal level. So I'm hopeful that states will see that CGMs benefit, benefit the states themselves for all the reasons that we've been talking about. So I would just say, in terms of like what to watch for, in terms of legislation or legislatures, I mean, it is concerning because states, and I worked in state government for a long time. I mean, the first thing, states do in budget situations like this is look to their Medicaid programs and figure out where they can cut. And as you said, optional benefits are usually, sort of the first on the chopping block. But I think it's going to be harder to go back with CGMs. But the concern I would have would be more around like reducing the covered population. So, maybe states aren't as quick to expand into type 2, would be one thing. And also just generally coverage generally, like if people are losing Medicaid coverage and there are, you know, uh, that they're going to lose access to CGMs. And, there was a question about the cost of insulin. And for Medicaid, the cost of insulin really is not an issue, or the cost of CGMs or any of that. But once you lose coverage, for everything, then it all becomes a problem. So, which is pretty obvious. But I just think that would be the more concerning part, is like larger cuts in beneficiaries
Yeah.
would be the concern. But hopefully with CGM coverage policies, we can hold firm.
Yeah, yeah, that's really helpful. And if anyone is listening, if there's any, I'm sure that all of us are stressed about the impacts of HR1, but if you have any specific like technical assistance um, needs, just a reminder to please reach out to us. We're happy to help provide more of a description of what the implications that states are going to experience because of HR1, but also we're happy to help sort of have this conversation around ensuring coverage and the importance of making sure that that helps lower costs for patients and not increasing costs for patients. Um, and
Mackenzie,
oh yeah, go
Mackenzie,
ahead,
just
Bruce.
one quick point. And I appreciate Greg. It's going to be hard for him to mess with the coverage benefit.
Mhm.
However, I'm starting to see states now starting to reduce reimbursements to physicians and hospitals. Today, for a clinician seeing a Medicaid recipient, they lose money. And if they're going to keep cutting that, how many physicians are going to continue to see Medicaid recipients within that particular state? So not only am I concerned about potential impact to CGM, what about that patient's overall health for other preventative service, vaccinations, immunizations, et cetera, if the physicians say, I just can't financially do this?
Mhm. Yeah, that's also a really good point. There'll be the other another issue too of health centers experiencing the reduction in funding and whether or not those health centers can stay open as well. So you have it's a to sort of build on the Russian doll metaphor, this is like a scalable waterfall of impacts coming from HR1. That's a great point, Bruce. And Honor, you mentioned how important kind of coalition partnerships were when it came to successfully pushing for improving coverage in Alabama. And, as I'm sure everyone on this call knows, Alabama is a state that's really historically exercised a lot of caution when it comes to expanding coverage and increasing their health spending. So, were there any specific data points and advocacy strategies that were really effective when engaging with the governor's office and the state Medicaid agency?
Yeah, and I'll start off by saying that in Alabama we're a little bit different. We are hesitant on legislative efforts when it comes to the things that our Medicaid agency is doing, just for the ability for us to pivot based on best practices. And I will also say it's important to understand your partnership with Medicaid outside of the legislative session in your Medicaid agency. And so for us, talking with Medicaid about gestational diabetes being added and the work that they're doing there, and I think our partners are the same way when we think about how do we see a change in Medicaid. Yes, it has to do absolutely with who's in leadership and their feelings and that, but it also has to do with how are we helping with implementation after we get something passed, and how are we having those conversations with Medicaid? Are we going to them first before we go to the governor's office to say, hey, we would really like this. What would it take to do this? Not just financially, but administratively, because we have to think through with them, okay, we have this new ability for people to get CGMs. How do we make sure all of your providers know? How do we continue to have to lift that up? How do we think through our remote patient monitoring system that this falls and or is going to be a part of, so that it works well within the system, so that the providers aren't trying to understand both CGM through Medicaid and CGM maybe through another insurance company, a private insurance company. So we're having these conversations outside of the legislative session, outside of policy, but even just administratively, how can we be part of the village that makes this happen? And respecting that our Medicaid and our states, we have resource scarcity. That's just that is part of thinking through a state budget. There's only so much money you have, and so normally when we go for policy and advocacy, we're saying, why is this thing more important than this other thing over here? But switching that conversation around from this is more important than this, that this is how this matches with this, and we can integrate that into the work that's being done, and you don't have to do it alone. You don't have, because Medicaid, when they're looking at money, they're not just looking at, hey, can we pay for this in our budget, but they're thinking, do we have the administrative power to do this well? Do we have the time and energy of our staff? And so being able to be a partner and going and saying, how can we help make this happen? And that might even be before you introduce policy of like what needs to be put in place so that this policy we're asking for, this extension of coverage we're asking for, is attainable. Because there might be something right in that way, and how can we help? And that might not be your organization. It might be a partner who can come in and step in and help and think through that with Medicaid, and getting that off the ground. And having and going to your Medicaid before you kind of go to your governor's office, but then also realizing that for us at March of Dimes, we are having larger conversations with the governor's office, because our governor's office is the one driving our rural transformation grant application. And so we're talking about maternal and child health because our governor has put that as a priority. And so we're already having these conversations. Medicaid's part of those conversations too. We have our transforming maternal health grant that we as a state are working on. So how does remote patient monitoring fit into that? Us CGMs fit into that. And then having that conversation overarchingly as a state, as this is a solution, this fits in with some of our priorities. And I know that not every state is having this as a, not every state is like, yes, let's talk about maternal and child health, or like, let's talk about continuous glucose monitors, let's talk about diabetes or chronic disease. But where does that fit? They're talking about health. So where does that fit within that broader conversation? And where can you have those conversations? And you don't have, such a supportive governor's office like we did with maternal and child health and the rural transformation funds. What are those things that you can be working on when that time comes, so that when you do get momentum, because right now in Alabama, we are really working hard on maternal and child health, and that's why we have some momentum. When you do have momentum, have you stacked the dominoes in the way that some of these administrative burdens that could prevent this from happening are ready to go? And so that's overarchingly thinking through House Bill 1, but also the Rural Transformation Fund, through the work that we're doing kind of strategically through our systems, has really been something that we've been a part of, and our partners in our coalitions with AAP, with Alabama Rise, with some of our other partners, them doing the work that they need, having those conversations, unified voices of this is how this fits into the bigger picture, and we all agree. And this is the evidence, this is the data, and knowing this is truly what we know works. Unified voices around data.
Yeah. And in addition to unified voices around data, I think another really powerful aspect of building out coalition strength is including and creating space for a really diverse group of storytellers in this work. And Bruce, can you talk a little bit about sort of the importance of storytelling, the importance or I guess rather, the importance of storytelling and what effects storytelling has on policy and health equity, and including a diverse set of storytellers in the work that you're doing, so that you're addressing the needs of marginalized communities and not just more broadly overarching needs as like a state as a whole.
I think if you look at policymakers, it's pretty straightforward. Their major objective is they want to get reelected. I hate to be crass, but it is what it is. When you have constituents within your state, and Honor, congratulations. When you built that coalition, you took single voices and created a choir. And then when you send a written letter in, you've got all those logos across the bottom. You're coming to the state with a solution as a diabetes community. They're not looking to pick winners and losers. The more logos you have on the bottom of that correspondence, when you have March of Dimes, when you have Families USA, when you have Greg's organization, guess what? They start looking at that and they're going, oops, maybe there's something here. And when you go in with evidence-based advocacy, here's the data. And there's three key things when you go in for an ask to a legislator. Here's the situation. I'm a patient with diabetes. Here's my challenge. My challenge is there's new medications and there's new devices available that I can't get access to. Then the ask. What I'm asking you to do is to be my champion and help me convince the state that there should be coverage for CGM so I can live a longer, healthier, and prosperous life and stay out of the hospital. Would you do that for me? And when you get those voices coming in from every angle, there's a rule of 7 with legislators. They may get a letter from one person, and the staff is going to capture it. The rule of 7 is once you have 7 letters coming in with the same message, that's when the staffer goes to the legislator and say, Houston, we got a problem. They're all coming in here saying the same thing over and over again. At that point, the legislator looks at his staffer and says, find out what's going on. And that's when the learning occurs within a legislator's office. But it takes time. And honor Greg and Ben and all you folks, I admire your tenacity because this is not a sprint. It's a treadmill. And you have to have the tenacity and the ability to say, at a certain point, legislators are going to look at you and say, Honor, I love you, but you're not going to leave till I do this, are you? So their polite way of getting rid of all of us in there hounding them politely is to pass the legislation and to get the policy fixed.
Thank you, Bruce. And to be conscious of time, since I know I want to get to the Q&A, I'm just going to move us right there. We have a couple of questions that came in through both the chat and the Q&A function. So I'll start with a question from Pamela Price. Are there any efforts focused on states in the South where there are higher rates of diabetes, particularly in rural areas? Greg, or my guess is Greg or Honor, would you like to take that one?
I like Greg.
I could speak for, in terms of the accelerator program that I described, we have a few states, but Texas and Oklahoma and that are in the South. Although I'm not. Anyway, but I know that there are other states that are. I think Florida is actually maybe doing some work in this area, but actually can't really speak much beyond that. So sorry about that.
No, that's okay. And I think this really speaks to, and as we've shown through the map, and honestly, as we've seen through everyone's remarks, right? Like this is a state by state effort. So we don't have a big like federal advocacy movement happening at this time. It really has been a really like local coalition driven effort. And so if there are specific states that you're interested in and you want to learn more, reach out to us and we can see if we can connect you with the appropriate coalitions that are doing that work at the ground level.
And
Because you're absolutely right. Oh, sorry. Honor,
and
do you want to?
I was going to add to that because I was
Yeah.
thinking, yeah, it's really state to state, but I will say again, March of Dimes, we had conversations about gestational diabetes and our Medicaid, but there's so much more that was going on before we ever had that conversation. That was not us. That was like our partners really pushing for just CGM coverage generally outside of children. Like that was just totally like a huge push. But thinking through some of those other larger conversations, I know like in my space, I'm part of conversations of multi-states in the South that are around maternal and child health. And this is one of those aspects. Again, Russian dolling it where I'm going, okay, we're going into these conversations about maternal and child health in the South. How do we put this as part of that? Does the data see this as something important? Yes, no, like let's have that conversation as a group. But while I'm doing that, then I have other partners who are part of larger coalitions for other health related things that might not be specifically maternal and child health related. So I'm not on those panels, but they're going to think through health related issues and bring this up as part of those larger coalitions. So just remember, if it is, yes, they're state to state when it comes to CGM coverage, but what are those larger conversations happening in the South about health where this can be a component of that conversation if the data shows that it needs to be?
That's perfect. Bruce, you came off mute too.
Mackenzie, one of the things that I've worked in the diabetes space specifically for over 30 years. I worked with one of my good friends, Gary Puckrin, with the National Minority Quality Forum.
Mm.
We created the U.S. Diabetes Index. One of the key pieces in those states in the South in the diabetes belt is that we can do maps based upon state Senate districts and representative districts to help them understand what is the impact of diabetes on their constituents. And we can break it down by age, gender, ethnicity, and how much is it costing their constituents. That helps get you when it's personalized that way. It
Mhm.
really garners their attention to say, I didn't know it was that bad. Well, you have an opportunity to be the champion to help these people with diabetes because diabetes, I carry the diagnosis, but my wife and my daughters are equally impacted. It's a family condition.
Yeah. I'm going to turn it back to you, Bruce, since we have time for one more question. There was a question in the chat from Kristen, who is saying that while increasing access via insurance plans to CGMs is extremely welcome, list price is one of the biggest barriers, aka, high deductible healthcare plans, uninsured, and Medicare, and what is being done to sort of address the list price of CGMs. And I know that's something that Families USA is not working on directly, but as someone who has worked in this advocacy space for a very long time, maybe you can direct Kristen, in the right direction when it comes to who else might be doing this work.
But I think it's being done across the broad board of the patient advocacy organizations. List price is a misnomer. But we're working a lot of insurance companies. They're looking at diabetes, that if I help people manage their diabetes, I'm preventing costs. I keep people out of the hospital. I keep people out of the emergency department. So they're looking at what's the fully burdened cost. So what's the list price and what the people actually pay? We know that we got the Treasury Department about 3 years ago that listed any blood glucose lowering medications or um, glucose monitoring systems could be a tax write-off for people with high deductible plans. So in those particular cases, and then we're also trying to educate people, if you've got diabetes and you go for a high deductible plan, don't do that. Your cash flow by getting a plan that'll cover your diabetes medications and management tools is a better investment than waiting to all of a sudden walking into the pharmacy and your insulin is $1,000. But I work with a number of coalitions that we got insulin at a maximum of $35 a month. So there's a lot of work going on out there. The Diabetes Caucus in both the House and the Senate have been great advocates on behalf of the diabetes community, and they're fighting every day to be able to drive it down. And quite frankly, the focused attention on the pharmacy benefit managers, some of their policies when it comes to chronic conditions are backing way off of and not looking at them as such a huge profit center. Because once you're under the scrutiny of the microscope, they don't like that because it impacts their look on Wall Street.
And Kristen, just like Bruce mentioned, there are a number of both coalitions, but also folks on the Hill who are focused on this as well. And so if I'll put my email into the chat, but if you'd like to be connected with individuals who are doing a lot of this work, please let us know. Families is very focused on affordability and ensuring that patients can afford both their medication, but also their healthcare more generally. And so we'd be happy to get you connected to the right folks and give you the information that you need. And with that, I want to give Tasha a little bit of time to talk a little bit about how to stay involved in this effort. So I'm going to turn it over to her, but I want to thank the panelists for participating today and for sharing all of their knowledge with us. We really, really appreciate it. And so Tasha, I will turn it over to you.
Thank you, Kenzie, and thank you again to all of our panelists, Honor and Greg and Bruce. It was so wonderful to have your expertise, your experience, and your knowledge, and just share that with all of our participants today. And I know we have a little bit of time, but I know you guys probably have a mountain of call to actions and end of the year things from all the work that you're doing. But as Kinsey said, we have resources that we here at Families USA, we pull together, and something that we do often is convene our partners that are doing similar work, that are doing the same work. And one of those ways is our upcoming Health Action Conference, which I have the privilege of being the lead for. So that is happening in January 22nd to the 23rd here in Washington, D.C. And so I don't know if any of you are planning to be here for that, but we actually will have a diabetes focused session during that 2-day conference entitled Diabetes Coverage and the Balance, How Advocates and Patients Can Protect and Expand Coverage in a Time of Change. And we'll have amazing panelists for that conversation too. And then there are more ways that we would love to keep you connected with our partners. And it's just like Greg and Honor and Bruce, as well as each other. And if you're having events that you'd love for us to promote, or any activations or anything that we can support you with in your work, please send us an email. You can reach out to myself or Kinsey here at Families USA. And I do know that after this call, we will be sending a follow-up email with resources that our panelists have shared with us today, as well as a survey, because we'd love to hear your feedback on if this information was helpful for you and if it was impactful. We want to do much more of this. We want to do conversations, and we want to be thought partners with you. We want to be allies and advocates in the work that you're doing. And so that also will come after this, along with information on upcoming events from our partners, as well as more information on the conference if that's something that you are interested in attending, because we'd love to see you there. And hopefully you have the time to share with us. And I'm looking to see what my colleagues have in the chat. I think that's it. I think I've covered everything. And once again, if we didn't get to your question and you want to have a conversation with us, please feel free to reach out to us. You can either follow up to the email that we will send after this, or you can reach out directly to myself, Kinsey, or anyone at Families USA who you may talk to often, and we'll make sure that we get you the answer that you need. And we thank you so much for joining this conversation today. And thank you again for our panelists for taking the time to join with us. Kinsey, is there anything else you'd like to say before we close out?
I just really want to thank everyone for joining. I want to flag that I added in a new resource, or not a new resource, an existing resource for March of Dimes on the Premium Reauthorization Act, which we didn't have a chance to get to, but is a huge priority for March of Dimes. I know Family has been a long-running endorsing organization of it as well, but we would encourage you to consider advocacy on this federal bill, but we will make sure to pass along more information about that as well. But thank you all for joining. As we've heard today, there are many opportunities to defend and expand and improve access to CGMs at the state level, and we hope that these ideas and resources and experts who share these ideas and resources help get you moving in the right direction if this is a space that you would like to jump into or continue to learn more about. And we know that the support, just as Honor was mentioning, support from coalitions, support from this broader network, us working together will be able to move all of us in the right direction when it comes to expanding coverage and protecting coverage. So thank you all so much. And if you need any additional resources and support, reach out to Families USA.
Thank you. And we did record this webinar. We'll be sharing it out later this week.
Yeah.
Have a good week, everyone.
Thank
Thank
you.
you.